live.
Good evening, Namaskar, and good evening, everyone. I welcome you all for today's webinar on Oncology Updates 2022, Lung and Breast Cancer. With immense pleasure, I would like to invite Dr. who is consultant medical oncologist, AIMS to carry out the further proceeding and to set the ball. Over to you, sir.
Yes, thank you, support team, and a very good evening, guys. Today on this platform, we are going to discuss some recent updates about the management of breast carcinoma and some recent updates in the lung carcinoma management. We will start with introduction part on NGS that will be taken by the Dr. Bijal Kulkarni. So I will invite Dr. Bijal Kulkarni for the role of NGS in lung cancer management. So Dr. Bijal is here.
Sir, just a minute, I'll just. Bijal sir is not joining. Sir, start with Dr. Tarachand sir.
Okay. So maybe dear Dr. Bijal has become occupied.
लेकिन इसमें उनका नाम
Anyway,
sir has a personal commitment, sir. Sir is not able to join, sir.
okay, fine. So with your permission, Tara sir, I will like to invite you for the next session then.
Yes, Sandeep, definitely. You are my good friend, and how can I refuse your invitation? So just I am starting.
So I will invite now Dr. Tarachand Gupta sir. He is faculty in medical oncology department in Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And sir is going to deliver a talk on the management of metastatic non-small cell lung cancers, some recent updates. So Tara sir, dais is yours.
Okay. Yeah, just 1 minute. Sorry, Dr. Sandeep, just I am starting my slides. It is a little bit lengthy, but I will try to finish in time. 1 minute. This is a little bit lengthy, and this is a complete, you can say, that lung cancer slides, and other than for all the driver mutations. And yes, I am starting. Are my slides visible? Yeah.
Visible, boss.
Yes, sir. Sir, kindly make it full screen.
Okay. So today we are going to discuss driver mutation positive metastatic lung cancer 2021 and beyond. Nothing has come in 2022 that's called new in the lung cancer, especially in driver mutation positive. So without going in the much epidemiology and nothing, I will go with this. The current profile is the for the treatment of lung cancer is either histologically based or depend and also the driver mutation positive. These are the different driver mutations which we search in a newly diagnosed lung cancer patient. EGFR, ALK, ROS, BRAF, MET, RET, HER2, and many more. And apart from this, we are also looking for the check anti-PD-1, anti-PD-L1, and some anti-CTLA4 antibiotics and immunotherapies are also there in the lung cancer treatment. And the question is what are the established and novel molecule based treatment strategies. So we are going to discuss that their driver mutations are the biomarkers as a response predictor and also the prognostic marker, we can say, because if we find the and targetable mutations, then the prognosis is usually better than non-driver mutation positive patients. So driver mutations are typically transforming and often important oncogene addicted biology to the transformed cell. Oncogene addiction tends to make driver mutations good biomarker for selecting patients for targeted therapy. So this is the extreme lines of crucial downstream growth and survival pathways in the cell upon a single upstream signal that is stuck in on the on position serves as an HLS heal. Matching a specific targeted drug to the identified driver mutation has resulted in significantly improved therapeutic efficacy. So different technologies are there to identify the driver mutations. This is the FISH, ISC, RT-PCR, and the NGS. These are the 4 types. However, if we go other than NGS methodology, and we want to identify the other targets, then yes, we need a more tissue and more time to identify the mutations. Because by RT-PCR we can identify only EGFR, BRAF, and MET. By FISH, ROS1 and ALK1. But for these we have to do one by one test, and then we will get the results. Around it will take roughly around 3 to 4 weeks, and the more and more tissue. But and in NGS, if we see that where by the NGS platform, we can do all the tests in a single go, and we can get that within the 2 weeks time, usually 2 weeks that we can get all the test reports and with a single tissue on it. So liquid biopsies are still having role, and these are the emerging technology. Yes, are most established in the lung cancer, especially in the EGFR case. When the blood-based tests are so-called, the liquid biopsies are gaining popularity because they provide the opportunity to genotype in a less invasive and less expensive manner. May offer a chance to monitor the molecular feature of cancer throughout the cancer treatment and predict the relapse. And cell-free circulating tumor DNA or circulating tumor cells are often present in the blood of patients with the lung cancer. Nowadays, the other cancers are also there. So recent advance in treatment in the treatment of EGFR mutation positive lung cancer. So most of the mutations are exon 18, 19, and 20 and 21. And the most common mutation among the EGFR is the exon 19 deletion, which is found in 46% of the EGFR mutated patients. And the second one is the exon 21. And the most drastic and only the poor prognosis is the exon 20 that is found in 4.1%. Rest is the exon 18. This is the NCCN current NCCN guideline recommendation, which suggests that in the EGFR, if the patient has discovered EGFR positive, then we can give the first line treatment as per this: osimertinib, erlotinib, opatinib, gefitinib, dacomitinib, erlo plus ramucirumab, and erlo plus PAP. While we are planning for the anti-EGFR molecules, then the factors which we should consider is the performance status, age or geriatric assessment scores, comorbidities, especially the brain mets, exon 19 or exon 21. Yes, finance the most important. And exon 21 preference, if we see the osimertinib, dacomitinib, Jef plus chemo, and erlo plus ramucirumab are the good options. And then we can see this is the another one is this is a printing mistake, that typing mistake. Left sided is the flora, and this is the archer, especially in exon 21. If we go with the forest plate also, and this is the Kaplan-Meier curve, osimertinib has lesser benefit and not good benefit in exon 21 as comparison to dacomitinib. However, this is only a cross-trial comparison, that is not an ideal situation. But yes, if we go in the detail in the trial, then we can find that in exon 21, the Archer is showing the very good results with the paclitaxel. Other comparative selectivity of EGFR TKI, we can see that for the gefitinib to inhibit the T790M, that we can see the more than 100 times of the current concentration it needs to inhibit the T790M. Afatinib takes around 10 times, that means the more potent than gefitinib, and osimertinib can affect in the usual doses can target the T790M. So any osimertinib can inhibit the EGFR mutation, EGFR exon deletion and L858 are both also the T790M, and this category, this is the only approved category and least activity for the wild type EGFR. So flora, that means the overall survival in the flora, we see that the comparative osimertinib is showing the 38.6 month survival as compared to the EGFR TKI first generation TKI, that is 31.8 with the hazard ratio of 0.79, around 7-month absolute benefit and the overall survival. And this osimertinib so the 7-month overall survival benefit. So with the more than 3 years of the OS, and patients are more likely to be alive at 2 and 3 years, as we can see that the 74% were alive at 2 years, and at 3 years, more than 50% patients were alive at 3 years in the FLORA trial on osimertinib. This is the Archer 1050 PFS by investigator assess ITT population in intention to treat analysis. So 30 at 2-year PFS is 30 versus 9.6, more than 3 times on the dacometinib arm. And number of median PFS was 14.7 months in daco arm versus the 9.2 months in the first generation arm. That is around 5 month absolute difference. Overall response rate, overall response rate and duration of response by independent review committee, that we can see in exon 19 deletion by the dacometinib versus the gefitinib, complete remission was observed in the 5.2% patient as comparison to the 2.3 in gefitinib arm, and partial response was 71.9 versus 67.7. So overall response rate is 70 versus 76%. In the benefit of dacometinib arm in comparison to the gefitinib, and we see in the L858R exon 21. So it is a complete remission rate is 1% versus a 5%, around 5 times. Overall response rate is nearby same, including the partial response and the complete remission. And median duration of response, we see the median duration of response is 15.6 months in exon 19 compared to the 8.3 nearby double. And in L858R, it is 13.7 versus 7.1, again nearby double. So head-to-head studies show that second and third generation EGFR TKIs provide the significant longer progression-free survival versus first generation EGFR TKIs. So usually nowadays the PFS is considered as a measure of drug benefit. However, in some trials it has been seen that it was not translated into the OS, but still we are considering the PFS as a measure of benefit. So this is how the difference between the first generation, second generation, and third generation TKI EGFR mutated. Resistance pattern post EGFR TKI, the most of the resistance comes from the transforming to the T790M around 50%, and other mechanisms are EGFR amplification, transformation to small cell lung cancer, HER2 amplification, PI3K, MET, KRAS, BRAF, epithelial mesenchymal transformation. So if the patient has progressed on the osimertinib in the exon 19 or L858R, patient has asymptomatic, we can see that we can consider in the oligometastatic or asymptomatic setting. If patient has the multiple METs, heavy burden disease or symptomatic, then we have to change to the chemotherapy. So this is as we have discussed. So landscape, now we are going to discuss the ALK positive non-small cell lung cancer. This is the landscape of the ALK inhibitors. In the 2013, we came with the first ALK inhibitor is the crizotinib and the ceritinib. Serotonin came in second line in 2016, in first line in 2018, and then serotonin in Asian subgroup analysis, serotonin in brain mets patients, serotonin, novolumab, other than alectinib, norlatinib, brigatinib, so on, like the crizotinib and alectinib. First line treatment of ALK positive non-small cell lung cancer, current status. So PFS this is the profile 1014 trial where the crizotinib was compared with the chemotherapy. In this, the progression-free survival, the absolute difference was around 4 months. At 18 months, PFS was 31 versus 5% in favor of crizotinib, with the overall response rate is near 74 versus 45% in the profile 1014. This was the ASCEND trial where the serotonin was compared with the chemotherapy. And then the progression-free survival was 16.6 versus 8.1 month, nearby double. At 18 month PFS was also the 50 versus 23% better than crizotinib, and overall response rate was the 72.5 versus 26.7%. This is the ALEX trial which compared the alectinib versus the crizotinib. In this trial, median we can say that 25.7 month versus the crizotinib was 7.4 month. PFS was observed in ALEX trial. So this showed the clear-cut superiority of alectinib in the first line setting, and cumulative of incidence of CNS progression, we can see there was 9.4 versus 41.4% in alectinib versus crizotinib, which shows that the crizotinib has the limited brain efficacy in brain mets, and alectinib is a good drug in first line brain mets patient. So this is the updated ALEX panel mature progression mature data of the progression-free survival. Alectinib, the final PFS analysis of ALEX demonstrated that the alectinib has the longest mature median PFS of 34.8 months, that the disease has not progressed for the 3 years in alectinib in the first line setting, providing a 3 times longer efficacy benefit comparison to the crizotinib. So cumulative incidence of CNS progression, as we discussed, 84% reduction as compared to crizotinib. Duration of response 33.1 month versus 11.1 month in favor of alectinib or crizotinib. The 5-year overall survival of the alectinib over the crizotinib, we see that this is on the Alcenza first line has a more than 60% overall survival rate at 5 years. So at 5 years, more than 60% patients have the survival the highest of any ALK positive therapy. After a median duration of follow-up of 48.2 months for the alectinib, OS data remain immature. 37% event recorded in the intention to treat population. So lorlatinib versus crizotinib, again we see that the median PFS not available by it was 9.1 month in the crizotinib, the hazard ratio of 0.21. Cost-effective sequencing with third generation ALK inhibitors. If we give the serotinib, it is the PFS is 16.6 months. Then chemo in the second line. Yes, so serotinib is a 16.6 month PFS. We give the first line chemo and then followed by chemo, then the PFS is around 19 months. Overall survival is this, and the crizotinib followed by serotinib and then chemo around 18.3 month survival. Serotinib 26.3 month PFS in Asian population and chemo, so overall survival around 28 months. Crizotinib followed by serotinib followed by lorlatinib around 24 months. Serotinib followed by lorlatinib followed by chemo 33 months, and alectinib 34 months first line PFS, crossing all the, and then followed by the lorlatinib and the chemo. This is the 41 month. So this is the NCCN guideline. Also recommend the alectinib, brigatinib, and lorlatinib both in the first line recommendation for the ALK as the ALK inhibitors in the metastatic setting of the adenocarcinoma lung, and other are the serotonin, creatinine we can consider. Resistance pattern for the ALK positive non-small cell lung cancer first line. Creatinine, some are unknown or non-targetable, then we can target by the second generation ALK inhibitor. If specific ALK kinase domain mutation conferring resistance like Z1202R, then it is lorlatinib. These are the 1151 other mutations. Sorry, it is hard to articulate. L1152, F1117, and this is in these mutations we can give the alectinib, brigatinib, lorlatinib both, and the serotinib, brigatinib, and alectinib in the L1196, ME12101, G1269AS1. So this is an extensive slide, I think, hard to interpret for me. Points to consider while using in the first line: superior efficacy in first line, why many patients may not survive to receive the second line. No brain mets at baseline, why? Because the use of brain penetrability guide prevent brain mets. Brain mets at baseline, use of brain penetrability guide to avoid a repeated radiotherapy in future. Symptomatic disease, use of agent with a rapid response, second line agent post progression. So we have second line option post first line progression. This is a ROS1 mutation in which the offered drugs are the entrectinib, crizotinib, or the serotinib. So this is the RAS-RAF-PRK pathway. The MAPK pathway regulates the cell signaling from the transmembrane growth factor receptor, leading to the cell proliferation. And this oncogenic mutation in the MAPK pathway, including BRAF kinase mutations, have been reported in the other cancers like the melanoma, colorectal, thyroid, and lung. And BRAF mutations results in the consecutive BRAF activation and uncontrolled signaling by the MAPK pathway. So KRAS mutation positive lung cancer. If first line is always, it is a chemotherapy. If the patient progress, then sotorasib is available. Not in India, I think, at present. When the BRAF V600 EPA condition, where davrafenib plus trametinib can be used as a first line therapy or systemic therapy followed by the davrafenib plus trametinib. So BRAF mutations in non-small cell lung cancer. BRAF mutation occurs in 1 to 4% of all non-small cell lung cancer adenocarcinoma. BRAF mutation typically do not overlap with other common mutations and SSC mutually exclusive mutation. It occurs in around 50 to 70% of cases caused by the point mutation in the BRAF kinase domain at position 600 is changed to the glutamic acid. Patients with BRAF V600 mutation have shorter median DFS and OS than patients without B600 mutation. So BRAF V600 has a histological features of aggressive tumor and worse prognosis with the platinum-based chemotherapy. So we should offer these BRAF anti-BRAF agents in combination with the MEK inhibitors. Outcomes in patients with BRAF positive patients, we can see with the first line platinum-based chemotherapy, it is response rate with the chemotherapy is 48 versus 29 in the BRAF mutated, while the median PFS is 6.7 4.1, and median OS is 15.9 versus 10.8 months. So patients with advanced BRAF V600 positive NSCLC have worse outcome with platinum-based chemotherapy. So this was the phase 2 study of this BRAF mutation. I don't go in detail, we'll go with the first slide. The progression-free survival was 10.9 months, and in independent assessor, it was 14.6 months. So in different cohort, this was the overall response rate with BRAF was 33% and the 33, 63, and 64. Median PFS was 5.5 months in the cohort A with the davrafenib monotherapy. Davrafenib plus trametinib in the second line setting was 9.7. While if it is first line, then it was 10.9 months. And duration of response is also the favoring the first line use of davrafenib plus trametinib. First BRAF mutated patients. The other nowadays are in the limelight of NTRK gene fusion. when the 1, 2, 3 are the positive, discovered prior to the first line systemic therapy, the preferred options are the lorlatinib or the entrectinib. Or we can, if we have started on the chemotherapy, then we can use on the progression the lorlatinib or the entrectinib. MET exon 4 skipping mutation, the preferred TKI is the capmatinib or tepotinib, and some circumstances can use the crizotinib. MET mutation is reported to be mutually exclusive and of other established molecular driver, including EGFR or ALK. MET mutations in the splice site leading to exon 14 skipping result in MET juxtamembrane gene of function alterations, originally discovered in small cell lung cancer and later in non-small cell lung cancer adenocarcinoma. MET exon 4 mutations occur in 3% of NSCLC adenocarcinoma, in 5 to 22% of other NSCLC. MET exon 14 mutations are linked to early stage diagnosis and older age. So MET X14 is associated with the worst survival. This is the MET exon 14 Kaplan-Meier curve. We can see this the drastic difference that in the MET is the wild type or the mutated. We can see that at 50 months the survival is very poor in MET mutated. And these are the poor responder to the immunotherapy also. In a retrospective study of 147 patients with MET exon 14 and NSCLC, 24 patients who received the immunotherapy were available for the response. Overall response rate was 17%, median PFS 1.9 months, and median OS was 18.2 months. Individual case reports suggest that the pembrolizumab might not be effective for NSCLC with high PD-L1 expression and MET exon 14. MET inhibition prolongs the survival in the MET mutated patients. In a retrospective study, patients with the MET mutated metastatic NSCLC treated with the MET inhibitor had prolonged survival compared with those treated with other therapies. Overall survival in MET mutated stage 4 NSCLC patients was 8.1 months for the patients who never received a MET TKI, 10.5 months for the patient with MET mutation only, and 5.2 months for the MET mutation and current application. 24.6 months for patient who received a MET TKI, crizotinib, gilactinib, and capmatinib. Capmatinib is a selective MET inhibitor, oral, ATP competitive, highly potent, and more than 10,000-fold selectivity for the MET receptor kinase when assessed against a panel of 55 other human kinases. This crosses the blood-brain barrier also, and potent blockade of MET activation in cell-based function and biochemical assay, as well as in vivo models. Compared with other agents, capmatinib is the most potent inhibitor against MET exon 14. So inhibitory concentration is the least for the capmatinib to inhibit the MET amplification is only the 0.6. In comparison to the savolitinib, it is 2.1, tepotinib 3.0, cabozantinib 7.8, and the crizotinib 22.5. The geometry mono 1 study designed the multi-center open level phase 2 study and evaluated the capmatinib in the first line and EGFR wild negative and MET negative patient when MET dysregulation was a central assessment. Treatment with capmatinib 400 mg BD. These were the results of this geometry mono 1 trial. The overall response rate was 67.9%. In the blind independent review by committee, investigators it was 60%, and in cohort 7 it was 65.6. So the majority of patients experienced a tumor response at first evaluation after initiating capmatinib with durable response. It was median duration of response to capmatinib was 12.6 months in the first line, 8.4 months in second line, and 9.7 months in the second or third line. Median PFS was 12.3 in first line, 6.9 in second, and 5.4 months in second or third line. So sooner is better. A clinically meaningful median overall survival of 20.8 months in the first line and 13.6 months in second line was observed. So I think the most.
Hello, sir. Kindly conclude your talk in 1 minute, sir.
Red rearrangement, the first line TKI is the self-personally prasalitinib or other are the cabozantinib, aratinib, and sunitinib by fish or NGS. These are the preferred as per the NCCN also self-percatinib and pralsetinib and cabozantinib. So conclusion for the targeted therapy for patients with a stage 4 non-small cell lung cancer and adenocarcinoma, component molecular testing is a standard of care. FD targeted agents approval for the treatment. Metastatic NSCLC, ALK rearrangement, so many lines, crizotinib, ceritinib, alectinib, lorlatinib, brigatinib, and so on. EGFR, afatinib, erlotinib, gefitinib, osimertinib, dacometinib, and ROS1, crizotinib, entrectinib are there, or the VRAF, dabrafenib, trametinib, or MAT, capmatinib, tapotinib, crizotinib, celpatinib, crizotinib, KRAS, sotorasib. So encourage the broad molecular testing for patients without ALK, EGFR, ROS1 mutations. Thank you. Any question?
So if there are no questions, then we'll proceed to the next session, and I'm going to talk about the recent developments in hormone positive and HER2 negative metastatic breast cancers. Host, can I share my screen?
Yes.
My slides are visible?
Yes, sir. Perfectly fine, sir.
Okay. So guys, let's proceed from lung to the breast domain. And these are my disclaimers. I'm going to talk about some basic details first. So this is the Globocon 2018 data showing that the breast cancer is one among the leading causes of new cancer cases and cancer-related death. And breast cancer occupies 11.6% of the all new cases diagnosed yearly, and 6.6% of all cancer deaths are related to the breast carcinoma. In India, the Globocon 2018 data showed that the number of new cases diagnosed with breast cancer is 1,62,470 per year. And in India, the breast cancer now ranks first in cancer incidence and mortality for women, and also both sexes combined. So, what is the landscape? 30% of women with early disease will develop advanced or metastatic disease during their natural history of disease, and 6 to 10% of all women with breast cancer present with metastatic disease at the time of initial diagnosis. The triple negative breast cancer subset occupies 15% of the all breast cancer cases, and hormone positive, HER2 positive patients combine a ratio of 15% among the breast cancer patients. HER2 positive, hormone negative patients represent 9% of the total breast cancer incidences. And the spectrum of this metastatic breast cancer patient is from virulent spectrum to indolent spectrum. Virulent spectrum is where there is a rapid development of metastasis, there is a short disease interval, and there is a extensive visceral involvement of visceral organs like lung involvement and liver involvement. There is a resistance to endocrine therapy. Indolent spectrum is where there is a long disease-free interval. There is a later recurrences of metastasis. There is a bone and soft tissue involvement. There is a 1 or 2 liver metastasis. There is 1 or 2 lung metastasis. And the disease is sensitive to endocrine therapy. So this is the diagram showing the molecular mechanism of action of CDK4/6 inhibitors. So cyclin D1 and CDK4/6 are the downstream signaling pathways that lead to cellular proliferation and regulate the G1/S checkpoint. The cell will gather his start his cell cycle from G1, G0 to G1, and then the cell cycle synthesis phase, and then the G2M. This is the cell cycle. The retinoblastoma is a tumor suppressor gene, which, when activated during its phosphorylated form, it will inhibit the G0 to G0 and G1S phase conversion, thereby leading to cell cycle arrest. Cyclin D and CDK4/6 combination will lead to inhibition of the phosphorylation of retinoblastoma, leading to the more active form of retinoblastoma available, leading into the G0, G1 and G1S phase cell cycle arrest. The cell will not go into the proliferation phase, leading into the quiescence of the malignant cells and control of the tumor. Palbociclib is the first-in-class CDK4/6 inhibitor. It is orally available selective inhibitor of CDK4 and 6. It inhibits the cell proliferation and cellular DNA synthesis, leading to prevention of cell cycle progression from G1 to S phase. In a low nanomolar concentration, it blocks the retinoblastoma phosphorylation, inducing specific G1 arrest in the sensitive cell lines. So, what are the updated indications of palbociclib? Palbociclib for women, it is indicated for the treatment of hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer, either in combination of aromatase inhibitor or in combination with fulvestrant in women who has already received the prior endocrine therapy and have progressed on that. In pre and perimenopausal women, the endocrine therapy should be combined with the luteinizing hormone releasing hormone agonist. And for men, palbociclib is indicated for treatment of HR positive, HER2 negative, advanced and metastatic breast cancer patients in combination with either an aromatase inhibitor or with fulvestrant in patients who have already received an endocrine therapy. So now I'll be discussing some efficacy data. These are global phase 3 trials. One of them is the Paloma 2, which is a phase 3 study which was designed in postmenopausal patients who are ER positive, HER2 negative. These are patients having advanced breast carcinoma who have not received any prior systemic therapy for their advanced disease. Prior adjuvant treatment with anastrozole or letrozole was allowed if the disease-free interval was 12 months or more than 12 months from the completion of therapy. Measurable disease according to RECIST version 1.1 or bone mineral disease were included. Included patients were having ECOG performance status in between 0 to 2. These patients were having adequate organ function and they were free from advanced and symptomatic visceral spread at risk of short-term life-threatening complications. And these patients were randomized in a 2:1 fashion in the experimental arm of palbociclib plus letrozole and the standard arm of placebo plus letrozole. This was a double-blind study done at 196 centers in 17 countries, and treatment was continued until objective disease progression, unacceptable toxicity, or withdrawal of consent. Crossover was not allowed. Placebo or palbociclib dose reductions were allowed per protocol. Letrozole dose reductions were not permitted. So these are the demographic data and baseline patient characteristics of the Paloma 2. 41% of patients belonging to the subset of patients having equal to or more than 65 years of age. 40% of patients were having ECOG performance status of 1. Visceral metastasis were present in the 48% of patients, and it was well matched among the both arms. 25% of patients were having disease at 3 sites, and 17% of patients were having disease at 4 or more than 4 sites. Disease-free interval was more than 12 months in the 40% of patients, and in the almost 22% of patients, it was equal to or less than 12 months. The pattern of recurrence was in most of the patients, it was distant. In 16% of patients, 48% of patients has received previous neoadjuvant chemotherapy, and 56% of patients has received adjuvant hormonal therapy. And these patient characteristics were well matched in between the two arms. So what were the results? As this graph is showing, palbociclib plus letrozole as first-line therapy in ER-positive, HER2-negative patients reduced a median progression-free survival of 25 months in the experimental arm, and it was 14.5 months only in the standard arm, which was statistically significant with a p-value of 0.000001. And in this forest plot, as we can see, the benefit of palbociclib was seen across the spectrum of disease, whether the patient is having visceral metastasis or bone only metastasis, whether patient has a treatment free interval of more than 2 years, more than 5 years, or equal to or less than 12 months. Elderly patients of equal to or more than 65 years, they also benefited from the addition of palbociclib to the hormonal therapy. Now, going ahead, investigator assessed progression-free survival in subgroups of patients. It was the median progression-free survival in the experimental arm was 36 months, and it was 11.2 months only in the standard arm in the patients of bone-only disease. Overall response according to the ITT population, the overall response rate was 42 months in the experimental arm of palbociclib plus letrozole. It was only 34% in the standard arm. Clinical benefit rate was 85% in the experimental arm, and it was 70% in the standard arm. Median duration of response was 22.5 months in the experimental arm, and it was 17 months in the placebo plus letrozole arm, denoting the superiority of the combination of palbociclib and letrozole. This was among the all randomized patient, and when I'm talking about the patients who are having a measurable disease, overall response rate was better in the experimental arm with 55% in compared to 45% in the standard arm. Clinical benefit rate was 84% in the experimental arm, and it was 71% in the standard arm. Median duration of response is also 22.5 months in the experimental arm and 17 months in the standard arm. And during follow-up, most of these patients received subsequent hormonal therapy or chemotherapy. And in this graph is showing that time to initiation of subsequent anti-cancer therapy was significantly delayed in the palbociclib plus letrozole arm in compared to the standard arm. The median event-free survival was 40 months in the experimental arm, and it was 30 months in the standard arm. So what are the conclusions? At the end of 37 months of follow-up, palbociclib plus letrozole consistently improved the median progression-free survival versus placebo plus letrozole in the overall population, which was mathematically 27.6 months versus 14.5 months, and it was seen across the patient subgroups. Palbociclib was well tolerated, with the most common adverse effect being neutropenia and leukopenia. However, the overall incidence of neutropenic fever was low, 2%. Even with the long-term follow-up data, the safety profile remained consistent with the previous observation, and no new safety signals were observed with the palbociclib and letrozole combination. Palbociclib plus letrozole should be regarded as an important first-line therapy option for patients with hormone-positive, HER2-negative advanced breast cancer patients. Now going to the Paloma 3 study, which was a double-blind study done in 144 centers in 17 countries. Hormone-positive, HER2-negative metastatic breast cancer patients were included. Other inclusion criteria were patients having pre or perimenopausal status or postmenopausal patients were included. These patients have already been progressed on an endocrine therapy while or within 12 months of completion of adjuvant treatment. All these patients have progressed on or within 1 month after treatment of metastatic breast cancer. These patients have received one or less than one prior chemotherapy regimen for advanced cancer. Patients were stratified according to visceral metastasis, sensitivity to prior hormonal therapy, pre, peri, and postmenopausal status. Patients were randomized in a 2:1 fashion in the experimental arm of palbociclib plus fulvestrant and the standard arm of placebo plus fulvestrant. Primary endpoint was investigator-assessed progression-free survival according to the RECIST version 1.1, and secondary endpoints included are the overall response rate, overall survival, duration of response, safety, and tolerability. And again, this table is showing the baseline characteristics of patients in between the two arms. Patients were comparable in both arms. Asian patients were 21% in the experimental arm and it was 18% in the standard arm. Pre and perimenopausal patients were 21% in both the arms. Visceral metastasis was seen in 60% of patients in both the arms. Disease-free interval of equal to or less than 24 months was seen in 18% of patients in both the arms. Aromatase inhibitors has been received in 85% of patients in both the arms. So patients were well matched, and the updated progression-free survival was 11.2 months in the combination arm of palbociclib plus fulvestrant, and it was 4.6 months only in the fulvestrant arm alone. And again, in this forest plot, as you can see, all the subgroup of patients benefited with the addition of palbociclib to fulvestrant. So pre and perimenopausal women or postmenopausal women, whether patient is having visceral metastasis or non-visceral metastasis, they all get benefited. Patients who have received previously aromatase inhibitor or tamoxifen, patients who have received 1, 2, or 3 or more than 3 lines of endocrine treatment, they all get benefited from the addition of palbociclib to fulvestrant. Even the patients who are PIK3C positive, they get benefit from the addition of palbociclib. Now the sub-analysis by menopausal status, the progression-free survival, which was the primary endpoint, was significantly improved in the pre and perimenopausal patients treated with palbociclib plus fulvestrant and LHRH agonist goserelin compared with the placebo plus fulvestrant and goserelin combination, consistent with the PFS benefit observed in the postmenopausal patients. So in the pre and perimenopausal group, the median progression-free survival was 9.5 months in the experimental arm, and it was 5.6 months in the standard arm. Same was seen in the postmenopausal arm. Postmenopausal patients, the median progression-free survival was 9.9 months in the experimental arm, and it was 3.9 months in the standard arm. And now the response rates according to intention to treat analysis. I'm not going in the detail of this table because these things has already been discussed. So absolute improvement in the median overall survival in palbociclib arm versus the placebo arm was 7 months, as you can see in this graph. And overall survival by sensitivity to prior endocrine therapy. Patient with sensitivity to prior endocrine therapy, they get a median overall survival of 40 months in the experimental arm, and the median overall survival was only 30 months in the standard arm, comprising of fulvestrant alone. So in the patients with sensitivity to prior endocrine therapy, absolute improvement in median overall survival in the palbociclib arm versus the placebo arm was 10 months. Patients without sensitivity to prior endocrine therapy, again, the median overall survival was 20.2 months in the placebo plus palbociclib plus fulvestrant arm, and it was 26 months in the placebo plus fulvestrant arm. So Palomar 3 conclusions: palbociclib when combined with fulvestrant significantly improved the median progression-free survival compared with the placebo plus fulvestrant as therapy in women with hormone positive HER2 negative advanced breast cancer who had progressed on one line of endocrine therapy. Median progression-free survival of 11.2 months was seen in the palbociclib plus fulvestrant arm compared with fulvestrant plus placebo arm, where it was 4.6 months only. Palbociclib was well tolerated, with the most common adverse effect being neutropenia and leukopenia. Palbociclib in combination with fulvestrant is an effective treatment option for women whose cancer has progressed on prior endocrine therapy. The absolute difference in PFS gain of 6.6 months with palbociclib plus fulvestrant was maintained for OS. 6.9 months. The 10-month improvement in OS was observed in patients with sensitivity to prior endocrine therapy. That is by definition of disease interval of equal to or more than 12 months from the last endocrine treatment. So now some important subgroup analysis. One of the most important subgroup analysis was seen in this table. Patients having comorbidities of gastrointestinal disorder, musculoskeletal disorder, metabolic disorder, vascular or cardiac disorder, they all get benefited from the addition of palbociclib. Their median PFS was in the range from 27 months to 30 months. And in the standard arm, it was 13 months to 14 months only. So palbociclib has a consistent efficacy and safety profile in patients with varying pre-existing conditions. Even in the elderly patient subgroup, as you can see in this graph, median progression-free survival was better in patients whether they are less than 65 years, whether they are 65 to 74 years, or in patients of 75 or more than 75 years age group. So in the elderly age group also palbociclib plus letrozole combination yield a median progression survival which was non-recordable in the experimental arm, and it was 11 months in the standard arm. And progression-free survival among patients with measurable disease at baseline, again palbociclib addition was yielded superior response. The median progression-free survival in patients who are having a measurable disease was 37 months in the experimental arm, and it was 27 months in the standard arm. Now talking about the Asian population, results from the Palomar 2 investigator assessed progression-free survival in the Asian and non-Asian patients. In Asian as well as in the non-Asian population, the addition of palbociclib to letrozole yielded a superior response rate and superior median progression-free survival as compared to the standard arm of placebo plus letrozole. It was 25 months and 14 months respectively in the Asian population, and it was again 27 months and 16 months in the non-Asian population. And as I go through again the results from the Paloma 3, investigators assessed progression-free survival in the Asian and non-Asian populations. The PFS was longer in the Asians with hormone-positive, HER2-negative metastatic breast cancer patients who have received palbociclib plus fulvestrant versus those who received placebo plus fulvestrant. Now, prognostic and intrinsic subtype and biomarker as analysis in patient with bone-only disease. Patient with bone-only disease, median progression-free survival was prolonged with palbociclib plus endocrine therapy combination compared with endocrine therapy alone in both Paloma 2 and Paloma 3. Regardless of whether patients had luminal A or luminal B subtype, palbociclib plus endocrine therapy improved progression-free survival compared with placebo plus endocrine therapy. And now the one most important point from the patient side, patient-reported outcomes. Addition of palbociclib to letrozole maintains the health-related quality of life and shows no significant difference between compared to letrozole alone, even with a longer duration of treatment in the palbociclib plus letrozole arm. These data support the favorable toxicity profile of palbociclib, which along with a significant improvement PFS seen in Paloma 2 supports the incorporation into a first-line treatment regimen. Paloma 3 quality of life assessment, again, significant better global quality of life compared with placebo plus fulvestrant. Addition of palbociclib yielded significant delay and deterioration of global quality of life. Significant greater improvement from baseline in emotional functioning was seen. Significant decrease from baseline in pain was seen. No significant increase in systemic therapy side effect was seen. And now the safety data about the palbociclib. Most common adverse effect observed were hematological, neutropenia and leukopenia of all grades were 81% and 45% respectively. Grade 3-4 neutropenia and leukopenia were seen in 10% of patients. And the degree of these cytopenia get gradually reduced. Landmark analysis using 3 landmarks, 3, 6, and 9 months demonstrated that PFS was similar among patients who experienced dose reduction versus those who did not in the palbociclib plus letrozole, meaning dose reduction doesn't alter the median progression-free survival of the patients. So Paloma 3 final safety analysis effect of dose reductions due to neutropenia on PFS. As you can see from this graph, there is no difference in PFS was observed among patients who had one or more than one dose reduction because of neutropenia versus no dose reduction, yielding which translated into more and more confidence among treating physician about the addition of palbociclib in the treatment arm. And now the adverse events after the dose reduction of palbociclib from 125 to 100 mg, incidence of neutropenia before and after palbociclib dose reduction from 125 to 100 mg was seen first cycle following dose reduction with the severity of neutropenia shifting to lower grades. So as the therapy goes on, the severity of neutropenia goes down. So what is the monitoring and adverse event management guidelines for the palbociclib? The CBC has to be monitored prior to start of palbociclib therapy and at the beginning of each cycle, and as well as the day 15 of first 2 cycles. For patients who experience a maximum of grade 1 or grade 2 neutropenia in first 6 cycles, CBC has to be monitored for subsequent cycles every 3 months and prior to the beginning of cycles and as clinically indicated. Grade 1 neutropenia is where absolute neutrophil counts are less than 1500. Grade 2 neutropenia is where absolute neutrophil count are in between 1000 to 1500. Grade 3 neutropenia is where the absolute neutrophil count is in between 500 to 1000. And grade 4 neutropenia is where the absolute neutrophil count are less than 500 per millimeter cube. So grade 1 and grade 2 hematological toxicities need not much management. Grade 3 neutropenia is where the absolute neutrophil count is below the 1000 and above 500. So what you need to do at that CBC on day 1 of cycle, palbociclib need to be withholded and the CBC need to be repeated after a week. Start the next cycle at the same dose when recovered to grade 2 or less. And subsequently, day 15 of first 2 cycles, continue palbociclib at the current dose to complete cycle, and CBC need to be repeated on day 22. Consider dose reduction in cases of prolonged more than 1 week recovery from grade 3 neutropenia or recurrent grade 3 neutropenia in subsequent cycles. Grade 3 neutropenia with fever of equal to or more than 38.5 degree Fahrenheit and or infection, or grade 4 neutropenia palbociclib need to be withholded until there is recovery of cytopenias to grade 2 or less and resume at next lower dose. And what about the QTC prolongation? And the data has come for this. Palbociclib, when added to letrozole, did not prolong the QTC interval to a clinically relevant extent at the recommended dosing regimen. So, has the palbociclib changed the treatment paradigm? Yes, it has. Prior to the early 2015, no new treatment options for advanced or metastatic breast cancer patients had been introduced since aromatase inhibitor for over a decade. Long-term data regarding the effect of palbociclib on PFS, overall survival, and the efficacy of subsequent therapy have been limited. All these data, these data tell us that the palbociclib plus letrozole in first-line metastatic breast cancer patients has shown a median progression-free survival of over 2 years, that is 27.6 months. The absolute difference in PFS gain was maintained for OS, with a 10-month improvement in OS was observed in patients with sensitivity to prior endocrine therapy with palbociclib plus fulvestrant combination. No evidence of specific cumulative or delayed toxicity with palbociclib plus endocrine therapy combination was seen. Monitor the complete blood counts prior to the start of palbociclib therapy and at the beginning of each cycle, as well as on the day 15 of first 2 cycles, and subsequently as on clinical indication. Quality of life maintained even with long-term treatment duration and high patient treatment satisfaction scores with both palbociclib combinations. So finally, I can say that palbociclib represents a substantial advance in the care of hormone-positive, HER2-negative metastatic breast cancer patients in first-line therapy with manageable adverse events and preserved quality of life for most patients with less and later use of chemotherapy. Thank you, guys.
Thank you, sir. Sir, kindly give concluding remarks, sir.
So, thank you everyone for being here on this evening. And I think a lot of new points about the management of lung carcinoma and breast cancer carcinoma are shared here. So, this will yield a change in your practice on the next Monday morning. And I wish a very good night to everyone.
Thank you, sir. Thank you so much, sir.
Thank you, sir. Thank you so much, Krishna Goswami sir.
Thank you, Krishna.